Welcome to Plastics in Practice. Today, our mission is mastering the management of wrist fractures, specifically the distal radius and the carpus. We're, cutting out the fluff and focusing on what actually matters in the OR and clinic.
Yeah, because honestly, there is nothing worse than looking at what you think is a perfect post-op x-ray of a volar plate, only to get a CT scan 3 days later and realize your distal subchondral screws are sitting directly inside the radiocarpal joint.
Oh man, the absolute worst feeling.
Right. You think you nailed the reduction,
Mm.
but you've basically just set the patient up for catastrophic cartilage wear.
Yeah, the wrist is definitely not basic carpentry. It's a highly precarious collision of mechanics and vascularity.
Exactly. We always want to treat bones like inert structural columns.
Mhm.
We see a fracture, categorize it, throw titanium at it. But the distal radius and the carpal bones operate under a completely different set of biological and biomechanical rules. If you do not respect the anatomy will humble you very quickly.
For sure. So before you even think about making an incision or applying a splint, you have to intimately understand how the wrist fails structurally. Let's break down the biomechanics of the distal radius, because in a normal wrist, force transmission is highly unequal. We're talking about 80% of the axial load going straight through the radius.
Yeah, and that ratio dictates everything. The remaining 20% crosses the triangular fibrocartilage complex and goes down the ulna.
Right.
So if your fracture reduction loses just 2 or 3 millimeters of radial height, you completely invert that load distribution.
Suddenly, the ulna and the TFCC are taking this massive amount of force they were never designed to handle.
Exactly, which leads to severe ulnar-sided wrist pain. Anatomically, you have to respect the 3 distinct articular fossa of the distal radius. The scaphoid fossa, the lunate fossa, and the sigmoid notch.
And when we look at the cortex itself, the volar side is considerably thicker and stouter than the dorsal side, right? Which perfectly explains the pathology of the classic fall on an outstretched hand.
Right. The patient lands in wrist extension, the axial load hits the distal radius, and the bone simply gives way on the weaker, thinner dorsal side.
Which gives you the classic dinner fork deformity.
Exactly. And in real life, recognizing that mechanical failure pattern tells you what to look for on your imaging. You have to scrutinize specific metrics. We are aiming for a radial height of 10 to 14 millimeters.
And radial inclination needs to be restored to, 20 to 25 degrees?
Yep. And volar tilt is critical. It averages 11 degrees, with a normal range between 5 and 15 degrees.
I always emphasize volar tilt to the residents. I mean, if you leave a wrist with a neutral or even worse, a 5-degree dorsal tilt, you permanently alter the contact mechanics of the radiocarpal joint.
Oh, absolutely. You shift the load dorsally, and you basically guarantee early post-traumatic arthritis.
And you cannot forget ulnar variance, where neutral is 0, plus or minus 2 millimeters. But getting those measurements means getting a perfect x-ray. You can't just accept a sloppy, malrotated film from the emergency department and expect to plan a surgery accurately.
No, that is a massive pitfall. A rotated film lies to you. For a true PA view, you have to look at the extensor carpi ulnaris groove.
The ECU groove, yeah.
Right. It must sit at or radial to the base of the ulnar styloid. If it is sitting ulnar the styloid, the forearm is supinated and your ulnar variance measurement is completely inaccurate.
The lateral view is just as notoriously difficult to get right, especially in a patient who's in pain. I always look at the pisiform.
Yeah, the pisiform is key.
The palmar cortex of the pisiform has to perfectly overlie the central third of the interval between the scaphoid and the capitate. If that pisiform is sitting too far volarly or dorsally, your volar tilt measurement is garbage.
Right. And once you finally have true orthogonal views, you have to categorize the damage.
Okay, so let me push back a bit here. I will be honest. When I look at the AO classification, those 27 subtypes kind of just blur together.
Not for everyone.
Right. In the actual OR, I am not thinking about whether this is a C3.2 or a C2.1. I'm just looking at whether the joint is in pieces. In real life, how much does memorizing that entire alphanumeric grid actually change your management?
Well, the extreme minutia won't change your incision, but the broad strokes of the AO system absolutely dictate your time in the OR. You have to differentiate between an extra-articular type A, a partial articular type B, and a complete articular type C.
Okay, so a type A might just need a standard volar plate.
Exactly. And a type B, like a volar Barton fracture, requires a buttress plating technique. And a type C often demands complex, fragment-specific fixation. The classification just forces you to respect the fracture personality.
Understanding that personality brings us directly to the reduction, moving from assessment to action. If we are starting with a closed reduction in the ER, a lot of junior residents reflexively want to use the extreme cotton loader position.
Oh yeah, they manipulate the fracture and then they lock the wrist in extreme hyperflexion and severe ulnar deviation.
Which is a huge mistake.
It is a historic trap.
Yeah.
You have to understand the pathophysiology of why it is dangerous. When you hyperflex the wrist, you stretch the median nerve tightly over the distal fracture fragment and the volar carpal ligament.
You're essentially creating acute, severe carpal tunnel syndrome.
Plus, the extreme deviation tightens the extensor tendons, creating unnecessary compressive forces across the radiocarpal joint. Just do not use it.
Right. If cotton loader is out, then the alternative is relying on the soft tissues to do the work for you. I find that sustained longitudinal traction is vastly underutilized.
Oh, completely.
You have to hang the arm, apply steady traction for, 5 to 7 minutes, and literally wait for the forearm musculature to fatigue and relax.
That is the right move.
Yeah.
Let ligamentotaxis restore your radial length.
Right.
Once it is out to length, apply localized palmar pressure on the distal fragment with just slight pronation and ulnar deviation.
Then you lock it in with a sugar tongue splint. The mechanics of the sugar tongue are brilliant because you get 3-point pressure to maintain that dorsal soft tissue hinge, but more importantly, it controls forearm rotation.
Exactly. It completely immobilizes the distal radioulnar joint while you wait for the swelling to subside. But, when that closed reduction slips, or you are staring down a highly unstable type C fracture, you are going to the OR.
Always.
And the volar approach, the Henry approach, is the undisputed workhorse for distal radius fixation.
The anatomy of the Henry approach is incredibly forgiving if you respect the planes. You go right between the radial artery and the flexor carpi radialis tendon.
Yeah, you retract the FCR ulnarly, protect the median nerve, and you are staring right at the pronator quadratus.
The beauty of this approach is that you elevate the pronator off the radius, apply your plate, and then let that muscle belly fall right back over the hardware. It acts as a biological protective barrier between your titanium plate and the flexor tendons.
It is a great approach, but it introduces a massive spatial awareness problem. When you put a volar plate on a distal radius, you are flying blind on the articular surface. You cannot directly see the joint line from the volar side.
Right. It's like putting a scaffold on the strong side of a building while flying blind on the articular surface. Which brings us back to that nightmare scenario I mentioned at the start. How do you confidently confirm your subchondral screws haven't penetrated the radiocarpal joint?
Well, standard PA and lateral fluoroscopy views will absolutely lie to you.
Yeah, they do.
The contour of the radial styloid and the dorsal rim will project over the screws, making a prominent intra-articular screw look perfectly safe. This is where the geometry of the wrist dictates your imaging. Here's the key point. Use a 22-degree elevated lateral view under fluoroscopy. That is the only way to reliably rule out joint penetration.
So break down the math on that for a second. Why exactly 22 degrees?
It comes down to the normal anatomy. The distal radius articular surface has an average volar tilt of 11 degrees. If you shoot a straight 0-degree lateral with your C-arm, the beam is tangential to the dorsal rim, but cuts obliquely through the volar rim. To perfectly profile that articular surface and see the true subchondral bone, you have to tilt the fluoroscopy beam proximally.
Ah, so you tilt it 22 degrees.
Exactly. That angle perfectly tangents the joint surface. It is the only reliable way to rule out screw penetration.
That makes total sense. Now, even with perfect heart replacement, the biological response to the trauma can cause chaos. Extensor pollicis longus rupture is a classic complication.
Oh, you see it constantly, sometimes even after a completely non-operative, minimally displaced fracture.
And it is rarely a mechanical issue. I mean, it is almost never a stray drill bit or a prominent dorsal screw rubbing the tendon. It is pure ischemia.
Right. The EPL runs through the third extensor compartment around Lister's tubercle. When the radius fractures, a hematoma forms.
And if the extensor retinaculum remains intact, that hematoma gets trapped inside the third compartment.
Yes. The pressure spikes, choking off the tenuous blood supply to the EPL tendon. It undergoes a vascular necrosis and simply snaps.
And the patient comes into clinic a month later, suddenly unable to lift their thumb off the table.
Yeah, and the fix there is an extensor indicis proprius transfer. You borrow the independent extensor from the index finger, reroute it, and get their thumb extending again.
We also have to talk about the median nerve. We use the 10 test in clinic. lightly striking the fingertips to compare sensibility. But I see a lot of debate on when to actually perform a carpal tunnel release during a radius fracture.
It is a controversial area, but the general rule is caution. Do not routinely release the carpal tunnel just because you have a volar incision open.
Right, because the anatomy of the flexor retinaculum provides crucial stability.
Exactly. You only release it if the patient has objective median nerve dysfunction that persists even after you have reduced the fracture, restored the anatomy, and taken the physical tension off the nerve.
Let's look at the ulnar side of the injury. Say you fix the radius, you check the distal radioulnar point, and it is grossly unstable.
The DRUJ is loose.
Right.
If the DRUJ is only stable when you put the forearm in full pronation, you have a major rehab problem. Do not immobilize that patient in pronation.
Because if you lock them in pronation, the palmar radioulnar ligament contracts and they will never regain their supination.
Exactly.
So what is the actual surgical move to stabilize it without ruining their range of motion?
You pin it in neutral. You position the forearm in neutral rotation, and you pass 2 parallel K-wires directly from the ulna below the ulnar head straight into the radius. You hold the joint in a neutral anatomic position for 4 to 6 weeks while the ligaments heal.
Okay, so moving distally across the joint, we hit the scaphoid. Because achieving perfect alignment on the radius doesn't matter if the original impact blew out the carpus. And the scaphoid operates under a completely different set of biological rules.
It really does.
If the radius is about structural support, the scaphoid is entirely about navigating a precarious vascular minefield.
It is an evolutionary design flaw.
Yeah.
80% of the scaphoid surface is covered in articular cartilage. That means the blood vessels have virtually no bare bone to penetrate.
And the blood supply is notoriously retrograde. The dorsal branches enter at the waist, leaving the proximal pole highly susceptible to a vascular necrosis.
Right, about 70 to 80% comes from those dorsal branches. When a patient sustains a waist fracture, the fracture line shears those interosseous vessels. The proximal pole is immediately cut off.
It is essentially living on borrowed time from the moment of impact.
Which is why missing the diagnosis is devastating. And standard PA and lateral films miss 8 to 20% of acute scaphoid fractures.
Yeah, you cannot rely on a standard wrist series. You have to get a 45-degree pronated and supinated oblique. But the most critical view is the PA clenched fist in ulnar deviation. I explain the biomechanics of this to residents all the time. The scaphoid naturally sits in a flexed posture. When you put the wrist in ulnar deviation, you physically pull the scaphoid out of flexion. You stretch it out flat, bringing its true profile perfectly perpendicular to the X-ray beam.
It extends the scaphoid to bring it into view.
Yeah.
Once you identify the fracture, the Herbert classification treats all complete waist and proximal pole fractures as fundamentally unstable. They need fixing.
And the standard is cannulated headless compression screws.
But getting that screw in is heavily debated. Dorsal versus volar approach. Both have serious trade-offs.
Right. The dorsal approach gives you a straight shot, making it mechanically easier to get a guide wire straight down the central axis of the proximal pole, but you risk the fragile dorsal blood supply.
Exactly. You risk killing the bone you were trying to fix. Now, the volar approach preserves that dorsal vascularity, but mechanically, it is brutal. You have to cut through the stout radiocarpal ligaments to expose the joint, and getting the correct trajectory into a small proximal pole fragment from the volar side is technically demanding.
The screw often just wants to skeeve right off the articular surface.
Yeah, it does.
If the fracture is missed or the patient ignores it, the biomechanics of the wrist collapse. You get scaphoid non-union advance collapse, or SNAC wrist, which follows a predictable arthritic pattern starting at the radial styloid. So let me push back here. What is the game plan for a late presentation? Say, a patient with a humpback deformity and frank proximal pole AVN.
In real life, that is one of the toughest salvage plans in hand surgery. You absolutely must approach it volarly. You have to physically pry open the collapsed scaphoid to restore its anatomic length.
And to hold that space, you use a corticocancellous wedge graft.
Right, but because of the AVN, a standard non-vascularized graft will fail. You need a vascularized bone graft.
Either the 1-2 intercompartmental supraretinacular artery graft from the distal radius or a medial femoral condyle free flap.
Exactly. You go down to the knee, harvest a wedge of living bone with its vascular pedicle, bring it to the wrist, and perform a microvascular anastomosis. It is a massive technical undertaking just to save a few millimeters of carpal bone.
The scaphoid isn't the only carpal bone fighting a losing battle for blood, though. The lunate has its own ischemic battles.
Right, Kienbach disease, lunate AVN. It is a perfect example of how wrist mechanics directly dictate cellular survival.
We classify it using Lichtman stages 1 through 4, but the treatment is driven by ulnar variance, right?
Yes, you have to look at the relationship between the distal radius and the distal ulna. If the ulnar variance is negative or neutral, the radius is taking a disproportionate amount of the axial load, crushing the lunate's microvasculature.
So you do a radial shortening osteotomy to unload the lunate.
Exactly. And if it's positive, you shorten the capitate. But late stages, stage 4, require a proximal row carpectomy or a total wrist fusion.
Moving beyond the scaphoid and lunate, the rest of the carpus hides traps you do not want to miss in the ER. The triquetrum is actually the second most fractured carpal.
But thankfully, it is usually benign. Just a dorsal chip from a radiotriquetral ligament avulsion.
The hemimate is a completely different story. Hook fractures from stick sports like golf or hockey.
Yeah, hard to see on X-ray. You absolutely need a CT scan. If you miss it, it can cause attritional flexor tendon ruptures or ulnar nerve issues.
With a hook of the hemate fracture, why is the standard in late presentations to just excise the hook rather than attempt ORF?
Because they're usually recognized late, non-union is already established. So periosteal excision is highly reliable, gets athletes back fast, and crucially protects the motor branch of the ulnar nerve.
That makes perfect clinical sense. Finally, we should briefly touch on the capitate. Look out for scaphocapitate syndrome.
Yeah, the proximal capitate fragment can literally flip 180 degrees.
Wow.
Yeah, so to quickly recap the core clinical pearls, master the 22-degree elevated lateral view for volar plates, respect the retrograde blood supply of the scaphoid, and always remember to check ulnar variance in Kienbach's.
Which brings me to a final thought on where our field is heading. We just discussed harvesting a medial femoral condyle free flap, doing microvascular anastomosis, all just to save a dead proximal pole of the scaphoid. It is a brilliant feat, but a massive physiological insult. Will we eventually abandon complex vascularized bone grafts in favor of simply injecting osteoinductive matrices and biologics directly into the avascular cavities of the scaphoid and lunate?
Entirely possible.
The tension between structural carpentry and true biological regeneration is exactly what makes plastic surgery so fascinating. Something for you to chew on before your next case. Thanks for scrubbing in with us today.